I want to start talking about disorders of childhood and adolescence. There are some disorders that are present, that can become present either in adulthood or childhood, and others that are unique in that they begin and sometimes even end during childhood. Diagnosis with kids is not as easy as with adults, and adult diagnosis is challenging as it is. But with kids, there are a variety of factors that make it tougher to figure out what's going on with the child. Behaviors, as always, are the result of a combination of biological and experiential factors. But with children, because they have fewer coping skills, there can be a variety of seemingly minor environmental factors that can cause chaos in a child's psyche. One other tricky thing about diagnosis with children is that labels can influence the development of problems and self-concept. So, for instance, if you tell a child that they have attention deficit hyperactivity disorder, they may use it as an excuse to be even more inattentive and rowdy and disruptive. Or they think of themselves that way, as something that there's something wrong with them or pathological, which isn't healthy either. As I mentioned, some disorders can be diagnosed in childhood that are similar to adult disorders. Childhood depression is similar to adult depression, except that it sort of shows itself differently. And in addition, some of these children will go on to be diagnosed with the adult form of the disorder later in life, even though the childhood symptoms may be different. So you might have a child show childhood-like symptoms of depression and then go on later in adult to develop a full-blown adult form of depression. And one thing Freud said that turned out to be true is that early childhood crises and traumas can set you up for later problems. So for instance, if you had a severe depressive episode because you lost a parent or a pet during childhood, that actually seems to change your neurology, or the physical structure of your brain, just a little bit in the direction of being more vulnerable to depression as an adult. Some disorders, on the other hand, as I mentioned, are unique to childhood and do not carry diagnosable behavior into adulthood. There's a wide range of childhood and adolescent disorders, and the number of diagnosable disorders is growing. The first DSM listed only autism and schizophrenia as specific disorders of childhood, and it also didn't differentiate between them terribly well. We also sort of lumped with autism and schizophrenia a number of other separate disorders that we now know are unique, like childhood disintegrative disorder or Rett syndrome. And now we have separated them out as separate, distinct disorders. DSM-3 listed 40 classifications of childhood disorders plus mental retardation. And again, it's really tough to diagnose kids, partly because of that developmental phenomena where their behavior can improve or disintegrate in rapid leaps and bounds, and partly because they're so sensitive to their environments, making their behavior and therefore diagnosis very unreliable. So there are a wide range of reported prevalence rates for the childhood disorders. The range of severity ranges from psychoses to milder developmental disturbances or adjustment disturbances. The prevalence of disorders among children in the United States is about 11%, but fewer than half are treated, so the real prevalence is probably a lot more than that. Another thing that we really need to study is the continuity of childhood disorders into adults. So what childhood disorders tend to lead towards certain other adult disorders. So far we know that conduct disorder seems to morph into antisocial personality disorder, and some might even say that oppositional defiant disorder morphs into conduct disorder when the kids get big and strong, and then into antisocial personality disorder. We also know that separation anxiety and school phobia are related to an increased likelihood of developing adult anxiety disorders. We're not really sure about gender identity disorder outcomes. And part of the issue there is that it may be the stigma associated with anything female that contributes to the stress on the child who identifies themselves as as female when they have the male genitalia. We also need to study attention deficit hyperactivity disorders forms in adulthood. We know a lot about the childhood forms, but especially people in my cohort that came along before the ADHD diagnosis was very popular might not have been identified as ADHD when in fact they were, and might be able to benefit from some of the new treatments for ADHD.
There are two types of childhood disorders, or categories of childhood disorders. One is internalizing, and the other is externalizing. And the externalizing disorders are a lot easier to see. They're things like conduct disorder, attention deficit hyperactivity disorder, and teachers can see them, parents can see them, neighbors can see them, other kids can see them, and they notice this extreme of childhood behaviors. And again, kids have a lot of energy and are kind of unsocialized starting out. So some kids will occasionally engage in some of the same behaviors, but these kids who meet the criteria have much more extreme versions of those behaviors. They're more frequent behaviors, they're more exaggerated behaviors. But again, externalizing has to do with the behaviors you can see, and therefore the disorders are much more reliably diagnosed. They're more likely to be picked up, and they're, in other words, noticed and brought to someone's attention, and it's easier to see whether the kids meet the criteria. Internalizing disorders are harder to see. They're things like anxiety and depression. And sometimes the kids with these disorders just seem incredibly well-behaved, mature, calm, but really they are fearful, maybe depressed, and it's hard for people to know, because the children also may have trouble expressing what they're feeling. They also kids tend to think whatever they're feeling is normal, or what everyone feels. And it hasn't been until relatively recently, that they've started to have screening programs in schools to try to figure out, which kids have depression or anxiety and are quietly suffering. So because the symptoms aren't easily observable, unless the child is afraid to go to school or exhibiting a lot of phobic symptoms, it's hard to diagnose them reliably. And in general, it's difficult to diagnose what's abnormal for kids. As I said, a lot of kids will exhibit randomly, occasionally, some of the symptoms of the disorders. And then on the other extreme, there's some children who exhibit a lot of the symptoms of the disorders a lot of the time. And then there's that middle ground. And that's because kids are energetic, and again, they need to be socialized, so sometimes they misbehave, and how much misbehavior is enough to meet the criteria. And that's when you need to take a good look at the criteria. But even with looking at the criteria, there are a lot of judgment calls on how serious a child's problem is, whether it meets criteria. And in general, there's also a lot of dissatisfaction and confusion with childhood disorders, partly because you can't always see what's going on in their heads, and they can't always tell you. But there's also more barriers to doing research with kids because of protections, which should be there, and also getting parental consent. The study my advisor did suggested that the children who have the most problems are the ones with the parents who are least likely to allow them to participate in research studies. So that's another confound. Something that's helped with the most recent version of the DSM is that they have been increasingly using behavioral criteria, so that at least for the disorders for which there are observable behaviors, we can get a better sense of whether children meet criteria or not.
There's some unique factors to consider when you're diagnosing children. And the most important is developmental norms. You need to keep in mind the norms for different ages, or the things that are typical of different stages of childhood, and the impact of labeling. In terms of behavioral norms, bedwetting is actually fairly normal or not unusual up to the age of 5 or 6, but we don't talk about it that much. it probably comes as no surprise that 2-year-olds tend to be stubborn and resistant to change. You've heard about the terrible twos. Well, there's a reason that they're called that. And so what's typical in terms of stubbornness and resistance in 2-year-olds would not be so for 6-year-olds. Okay, so you have to keep in mind the age. Separation anxiety is normal from 8 months to 2 years, but if it persists past the age of 3 or 4, then it's a problem. And about a third or more of children will engage in the following behaviors on a fairly regular basis. Specific fears between the ages of 1.5 and 5, which may serve an adaptive purpose in that it keeps the children close to their adult caretakers. Temper tantrums, disobedient, unfortunately, most of childhood. And that's part of socialization. Now, this doesn't mean we should encourage or allow or ignore these sorts of symptoms. It just means that these things come up at those ages. They're not necessarily a reason for concern, but they do need to be socialized out. So discouraging temper tantrums and encouraging obedience and helping kids cope with their fears are very important. So the kids at that age are still under the process of socialization, and they need those sorts of pressures in order to grow and mature. Demanding attention between the ages of 1.5 and 9 years old, unfortunately. Abundant energy, especially when they're young, 1.5 to 5 years old, which makes it really hard to reliably diagnose attention deficit hyperactivity disorder at that age. Shy, oversensitive, between the ages of 3 and 9, and girls and adolescents. Whining, again, unfortunately, the ages of 3 to 9 years old. It's fairly common to have whining. Arguing, lying, showing off, which sound very severe, again, ages 3 to 9 show these. About a third of kids ages 3 to 9 show these behaviors on a regular basis. And again, this doesn't mean they're okay and desirable and should be accepted. It just means that kids at these ages do those things, and what you need to do is just keep socializing them out of these behaviors. Some more factors to consider when diagnosing children. Most importantly, kids don't know what's normal. So their home life could be totally bizarre, and their parents and their sibs might be acting very outrageous and treating them unusually, and they won't know because that's their world. So they're not going to be able to tell you what's normal and what's not in terms of problems. And children's ability to express themselves is limited by their age, both in terms of language development, whether they know words, have insight based on being able to label emotions, their conceptual ability. And with anyone you're diagnosing, you need to get an assessment of their intellectual resources, because that determines what's normal and what's not, and how much we should be able to, how much they should be able to cope with different situations. And mood and thinking. So with kids, moods tend to be rather extreme. They haven't really learned to modulate their emotions, and their thinking is a little more simplistic than adults. They haven't really learned how to, especially at the younger ages, how to deal with shades of gray. So all these things impair a child's ability to tell you that something's wrong and what it is. This is a non-psychiatric example of this. My sister and I took my niece up on the boardwalk, and we were going to go for lunch, and niece was hungry, and she'd been otherwise well behaved, but she started getting really cranky and miserable and screaming and crying, especially when we were in the restaurant, which is unusual because she usually likes food and looking around, sitting at the table. But she was crying, she was cranky, she was making a lot of noise, and there were some, little patches of red that were showing up on her face, but she wasn't running a fever or anything, or pink that was showing up in her face, but she wasn't running a fever or anything. And we struggled with her and asked what was wrong, and did she have a bellyache? And no, she didn't have a bellyache. And she was very uncomfortable. Finally, we just went home. And on the way home, my sister wrapped a beach towel around her. And suddenly, Linda Kate was quiet and well-behaved again. The kid was cold. And that's just cold. And I think she was like 4 years old, so she knew what being cold was. Imagine a child suffering from depression or anxiety or some sort of fear or phobia or other psychological problem. They're certainly not going to be able to tell you how they feel and what's upsetting them if my niece can't tell you that she's cold and that's why she's getting so cranky. Again, children don't refer themselves. In order for a child to come into treatment, and in order for you to treat them, they have to be accompanied or brought by an adult. Even if they were to show up at your office, they couldn't be seen because of the consent laws. And that's the next line here. They can't give informed consent for treatment, even if they did self-refer. And the other really tricky things is that laws vary on this from state to state. One of the exercises I did with my doctoral class one time was to have them gather and compare state laws for particular issues, like reporting child abuse or age of consent. And that can vary for psychological treatment from medical treatment. They can all be separate and very individualistic. With child abuse, when you report, what you report, who you report it to, and how you report it, and what the consequences are if you don't, all vary from state to state. So always become very familiar with your state law, especially when you're working with kids. There was a big ethics case in which someone had gotten consent for treatment from one parent, the parent who was in charge of the child, the one that had custody, custodial parent, and the parents were divorced, and the other parent sued because the psychologist didn't get consent from both parents. And just because parents say there's a situation legally doesn't mean it exists. So always document and be really careful when you're working with kids because of that issue. Some more factors to consider when diagnosing children. Furthermore, children's behavior depends on a variety of forces way beyond their control. As I've mentioned already, they're less able to control and modulate their responses to environmental events and even to illness. The environment, such things as exposure to structure, consistency, and things like that can have a big impact later on, especially in school. So if you've had a child who's been allowed to run loose and hasn't had much structure, and then they hit kindergarten or first grade, it's going to take them a while to settle in. And that can look like ADHD. But with ADHD, it persists, and the kids don't settle down and adjust to the new situation. But what you're used to as a child dictates a lot of what your behaviors and what you think the expectations are in other environments. Compared to adults, kids are more dependent, more easily manipulated, and more vulnerable to what adults tell them, whether it's true or not. And that can be a problem. So kids will often sort of act out their parents' schema about what's going on, who's to be trusted, who's not, what's good, what's bad. And maturation can play a factor too. Kids tend to grow in spurts and delays. It's really hard to accurately assess IQ for this reason, but the same goes for behavior. So they might be very immature and behind their peers emotionally and in coping skills for a while, and then they may jump ahead, and then they may stay at that level. So there's a lot of variability in terms of maturation and their ability to cope with situations. Crises can also have unpredictable and sporadic reactions. Crises can be related to adjustment to divorce, the birth of other children, the death of a pet, or, like I said, moving the couch or some other, changing bedrooms or something. Anything like that can have unpredictable reactions in children because it upsets their world order. And they have very limited coping skills. You want to see a child, you've seen a child try to walk before they're really coordinated at it. Even, once they've gotten the knack of walking, it takes a lot more effort to navigate around tricky terrain. Well, the same goes for emotional terrain. They really have to think, and they stumble, and they have some trouble dealing with touchy emotional things and strong emotions. You can also have scapegoating, as I mentioned. The child could be seen as the cause of all family problems, even though they're not. And biological factors, illness or predisposition to certain sorts of problems. Family dynamics, if there's a lot of fighting, conflict in the family, that can increase the likelihood of a child acting out just from the anxiety and discomfort of it all. And then culture. What the children are socialized to behave like can play a role. What the expectations are, what the belief system is within the family can also play a role in what sorts of behaviors you see in them. Also different ways to conceptualize children's problems. A syndrome might be viewed as, in other words, a pattern of behavior might be viewed as something that's related to their internal personality or character that is going to generalize and extend beyond the precipitating event, or it could simply be a reaction to stress, or it could be a collection of behaviors in response to a collection of events, or you could have multiple syndromes. It could be a number of problems that the child is having. There's also a big problem with labeling children, as I mentioned before. It pathologizes the kid, for one thing. It makes them feel, because they're going to hear the label, no matter how much you try to hide it from them, it makes them feel like something's wrong with them, like they're inferior, or like you can feel that way. And some people think, partly for that reason and partly because of the reality of systems playing a role in people's problems, that we should diagnose the family system. At the very least, we need to identify types of family processes that are related to problems like we have for schizophrenia. A lot of conflict in families tends to be associated with schizophrenia. We also need reliable and valid family diagnoses if you want to look at the system. And as a feminist, as I mentioned, it is sort of a misnomer because it's more of a societal systems perspective. I think we should diagnose societal systems as well, because it's those systems in which families are embedded, and from the combination of those things, problems can arise. Another issue is that labels may create self-fulfilling prophecies. So if you tell a child they're ADHD, they might stop trying to control their behavior. You tell them they're retarded, or they hear that they're retarded, they don't push themselves as much. For instance, you've probably all hit a problem or a topic or a subject that you had trouble with, and yet you persevered because you figured you could, if you just tried hard enough, studied hard enough, master the material. Well, if you're told you're mentally retarded and not capable of mastering some material, you may just say, "Yep, never mind, this is just too hard for me. I'm mentally retarded, I can't do this." And once people expect or don't expect things from you, that can make a difference too. I had a school psychologist I was shadowing in high school fudge the score on an intelligence scale and make it a little bit higher, so this little girl would be placed and mainstreamed rather than put in a special needs mentally retarded classroom, because he thought she would be challenged more if she were mainstreamed, whereas if she was put in that other classroom, less would be expected of her and therefore she would achieve less. Some people, in order to sort of avoid the whole diagnosis issue, will give multiple labels and rule out diagnoses later, but that leaves the child with more labels, such as both conduct disorder and ADHD. And some people avoid labels by labeling an adjustment order, but it's not a good solution because it doesn't communicate much and it's still a label. In other words, it doesn't help you figure out what treatment would be best and what sort of planning you need to do, and yet the kid's still pathologized and stuck with the label with no good outcomes. In preschool kids is especially problematic, again, because of the mixed information about the reliability of diagnoses. In other words, reliability is low. You're going to find people saying the kid has one problem and then a different sort of problem because just small changes in context can make the child act differently. And again, IQ tests aren't even reliable at lower ages because of that growth spurt issue, where kids spurt ahead and then drop behind and back and forth. And it's also tricky because preschool kids have a ton of energy, as I mentioned during the normative comments. So it's hard to know whether these are just kids with normal energy or if they're hyperactive, and if the aggressiveness is true meanness or just not quite socialized enough yet. And so all of these things present a real challenge. When I was in training, they were trying to have us do play therapy, which is coming from a cognitive behavioral program where I'd been taught it was silly, was kind of hard to get used to. But when you're doing, having them play with toys and little dolls and houses and in sand where they can set different sorts of scenarios up, it really does help you get a sense of what's going on in the child's head without relying a whole lot on their language. So maybe we need to be a little bit more flexible and at the same time try to develop some empirically valid systems for communicating with children through play and other sorts of nonverbal techniques, or non-traditional, non-adult oriented techniques.